be hosting this session, and I would like to extend a very warm welcome to each one of you who have been connected with us through our iTalks webinar. Well, I would like to thank you all for taking the time out from your heavy schedule and marking our program with your glorious presence. Thank you for joining with us, and also don't forget to subscribe our YouTube channel for being updated to our programs even in the days to come. For now, I would like to step forward to inaugurate today's session, and also I would like to let you all know that we will be having our discussion session at the end of the webinar. So if you get any queries in between the session, just drop them on our comment section. We will get back to you afterwards. As we all know, there are several factors that can cause fall in day-to-day life, but among them, poor vision, either in quality or in quantity, has been the major cause of it. This fact transparently reflects how important is the role of every eye care providers to identify the patients with poor vision, manage them properly, and ultimately guide them to reduce fall. Today with us, we have our delegate, Dr. Krishna Kumar Ramani, who will be talking particularly about the role of optometrists in reducing falls. Before that, I would like to give his introduction in general. Dr. Krishna has completed his UG, PG, and doctoral studies from Elite School of Optometry, and also he has done Masters in Psychology and Fellowship in British Dispensing Optician. Previously, he was attached with Sankara Nethralaya as the head of Optometry department for 7 years. Further, he has also been associated with Elite School of Optometry as an optometry principal for 16 years. At present, he has been serving as a freelance optometrist and an educator. Welcome to you, Dr. Krishna, for today's session, and thank you so much for your presence.
Thank you. Salu. And it gives me a great pleasure to be invited by a wonderful young team of Nepal Mero group. And I could see that I was telling Kapil that I was going through your website on Mero Eye Foundation. The objectives was really wonderful. I really appreciate you and the team for your great activities for quite a long time. And no doubt with this young team, Nepal Optometry and Eye Care and Vision Care is going to see a lot of laurels down the line. And very proud that I have been invited, and it's a great privilege for me to talk on a subject which has very often been neglected by eye care field. So that's the only reason why I thought, as an optometrist, whether we could definitely fall in line to talk more on falls. And even before I start sharing about what I know about falls and what are the works that we have done so far, I was thinking that I should fondly remember Nepal itself. First, through my wonderful students from Nepal, right from, I think all of them are doing wonderfully well. When I was a principal and when I was a HOD of Optometry, I came across one Mr. presently Dr. Ram Bahadur. At present, he is actually doing his practice in US. And other gems I know is Nabin Paral. I think he has just finished his master's from Amity, and at present he's practicing Pokhara. And very good, I think his cousin brother, Madhavan Bandari, I know he did both undergrad and masters with us. And he had a short tenure in Malaysia as a faculty member. I met him there too. And at present, he is pursuing his doctoral program in QET, Australia. And Jitumuni, who did his undergraduation, and then he did MPH from Chennai, some other university. And at present, I understand, and he's practicing as a public health person in Assam. So I am well connected with Nepal, and at present we have one of my students for occupational optometry doing her master's. She's also from Nepal. So Nepal has got a lot of links with me and my institution. Still, I have Great regards for all the students, and all of them did it or were doing very well during the studies, and well-behaved people, and they have contributed enormously to eye care later on. But I can't forget this day, which 1 week I was there. Please forgive me for the photo quality, because I digged out from my collection of those days of 2001. I never had a mobile phone. And when I visited Kathmandu for the SARC ophthalmology conference, I still really know remember that can visualize those time. And I met two people there. One, Dr. Anil Kumar in Nepal Eye Hospital. I went around that place, government setup, and I remember that time that 97 you people started the first school of optometry. I met some of the ophthalmic assistants and ophthalmologists. I remember Dr. Anil Kumar because he did his fellowship program with us at Sankara Nethralaya at those time. And later on, I took a flight along with my two of the giants in ophthalmologists, one Dr. Lingam Gopal and Dr. Tarun Sharma, who has seen the two extremes of this photograph. We went to Pokhara. I was there in Himalaya High Hospital and met this Dr. Bayanju. Ranganath Bayanju is also did his fellowship at Sankara Nethralaya. I remember at present, I'm not in touch with both of them. But I know that he's doing very well. I remember 2018, he was being given some award for being a hero of eye care. So well connected. I'm extremely happy. I came to that place, and I always feel that is a place where anyone should travel and get the peace of the world. And once again, I want to congratulate each one of you who are doing wonderful job at Nepal and eye care services. Now, with this, I thought I will move to the contents. The contents will be of fivefold. As much as possible, I will keep it short, and I will see if I will take up more questions than what I talk. So I will be talking first about the population of elderly population, world scenario, and specific to Nepal, and the prevalence of falls in the world scenario, India and Nepal, and some of these studies which we picked up from some of the works being done by your group, and also highlight the importance of risk factors where we can connect how, as an optometrist, we can play a role in falls reduction, and why there is a need for this new specialty as a natural outcome of this talk. And where, as an optometrist, you can play a small to big role depending upon your interest and time you have with you. The global population of elderly are overall, it is increasing. We do say that bricks have been added because of better quality of life anywhere in the world. But if you look at the mid-range between 40 to 65, the bricks are really big enough and it is really increasing. Or otherwise, if this data is around 2004 or 2025, we are going to expect in another 10 to 25 years the bulging of this central to apex area, and therefore we are going to handle huge number of elderly population. And we are all very well aware that elderly population means it also goes with a lot of eye related challenges, and naturally the consequence out of it, one of the consequence will be definitely eye related conditions. And if you really look at in relation to World Visual Impairment Index and blindness, it is two actually at present. We are handling around 285 million people who are affected with visual impairment that includes low vision and other aspects as well as blindness. And low vision, almost it's 246 million, almost 86% of it, and 14% of them are blind. And this scenario is even worse when you go into the developing countries like ours. And one nice thing is almost 80% of these visual impairments is avoidable. And we all know that as an optometrist, as a primary care person, definitely we can play a huge role in order to be preventing these aspect. And we know what are the causative factors. Cataract and uncorrected refractive error still playing a big whole role. and under the avoidable visual impairment category, and unoperated cataract and glaucoma are the leading causes of avoidable blindness. And closely catching up is diabetic retinopathy and ARMD, and with the lifespan increasing, we are going to handle this at least 3 to 4 of these conditions down the line. And we know how to handle uncorrected refractive error, but we don't know if someone is not wearing the correction, what are the life equality of life issues that he is going to have, especially his activities of daily living will be very, very challenging. And when you look at this population of which you are familiar with, Nepal, and we are going to have Nepal, we know the Nepal's population as of today, I was just going through, almost nearing 3 crore people, which is actually, maybe if you put together 2 or 3 metros of India, we are going to have that many things. It looks small, but the challenges are high. We are, at present, you are dealing with almost 5.73, almost 6% of more than 65 years of old, or it says that greater than 50 years expected today is almost 20% of Nepal population. That means we are dealing with almost 16 million people with elderly population as of now, which definitely required to be cared very well beyond what we are doing today. And we're really looking at the causes of blindness. It's almost a similar picture anywhere in the world. Cataract plays a huge havoc. But interesting thing is preventable blindness is 16%, treatable blindness is 65%, and permanent blindness is 19%. Our focus is more towards low vision, severely visual impairment, and moderately visual impairment, where actually even in Nepal, this percentage is almost increasing. Put together, they have dealing with almost 20 percentage in this category, which required. Now, until then, the pictures are all very interesting, and we all know what need to be done, low vision care to be given. All these things are fantastic. Now, what are the challenges, especially elderly population feel or faced in their day-to-day life, which each one of us will definitely will have elderly population with us, dealing with the social and cultural changes, the fast changing scenario, how to adapt to this scenario is the biggest shock all the time. And every time they got accustomed, I think there was a time that every change happens is only 30 to 40 years once. And later on, it was around 10 to 15 years. And now it is happening every now and then. So this dealing with the social and cultural changes for elderly was accustomed to this non-changing environment, to a fast-changing environment, not only in the infrastructure, but also in terms of the way they have to deal with individuals is becoming a bigger challenge they do face. And therefore, that leads to a lot of medical and psychological problem dealing with these 2 issues. So these 2 issues, of course, is not part of our today's talk, but these 2 are very, very important and phenomenal. Maybe as a geriatric care, try to put together all these things and try to see whether we can bring in change as an optometrist, or at least a common man, or through your association. But what does this expert say about the commonest and most biggest pertinent issues today, most for the past 15 to 16 years, is the geriatric giants. This is what I call it, geriatric giant. It is the bigger problem for geriatric population. And this falls, it becomes a bigger challenge. And if we could deal, if we could contribute as an optometrist in small way, definitely we can see that we have contributed to their avoidance or at least reduction of the falls among this elderly. Now, for us to understand what is fall, the fall is a very simple definition. It's an event which would have happened accidentally, which results in a person's coming to rest inadvertently on the ground or floor or other lower level. That means if they unavoidably or accidentally hit upon something and coming down, the whole body coming down is a cause for concern. And believe it, it's the second leading cause for unintentional injury among the elderly population. Now, what is the consequence of the falls? Probably that will tell the story. The consequence of falls are 3 important things. Of course, not going for hospital after that, or not getting hospitalization, is one group. Hospitalization is a very common one after the fall, and surgery and going through a newer equipment, so that again getting adapted to it is another challenge. Going through a rehabilitation process, going for home health services, bringing physiotherapist or occupational therapist to the play, and institutionalization of being adapted, admitted into some of the nurseries to take care of old age home, and having this emotional and physical personal costs for individuals. These are the consequence, looks very vague, but if you really look into each of it, the cost is very, very high. And depending upon whether you are a rich, whether you are a middle class person, or you are a poor person, the cost and the consequence are going to be the same. Money alone is not going to achieve everything here, but it is going to be a proper care and service idea, like what Mero is doing for the community. Probably Mero can have an idea that why not they start a community care for geriatric population at the doorstep, and ask a simple question and whether they had any fall. That will add a value. And if you could contribute and find out what are the probable reason, which can be, reason can be threefold usually. It can be a person have losing a balance and falling down is because whether his vestibular system related to ears, we are not the masters, but at least if you know it has got any ear related problem, probably his balance imbalance is because of this vestibular in nature. Somatosensory to do with a muscle weakness, a locomotor issue, especially the lower limb area. It might be a nervous or muscle, or it can be a bone related issues. And if they are going to fall, probably is we can think about whether referring them appropriately. And the third important component on visual related thing, it can be visual deterioration, his vision is poor. So we know falls, and falls is related to the balance issues, and this imbalance issue can be caused by vestibular need, it is related to ears, somatosensory, it can be related to muscular, bone, nerve related issues, or the vision related issues. It can be all three folds. I'm not getting into the fine details of the gait analysis and stuff, but at least for a beginner, you try to relate these three important reasons. Now, what is exactly it is causing this morbidity and mortality are the bigger challenge, especially dealing with these people. It is an indicator if someone says, I had a fall, that is indicator that physically and cognitively he is very poor, and it is a significant burden on society. At least the National Health Services has shown that almost 2.3 billion pounds per year has been spent on this estimated cost on falls in England. And definitely countries like us, India or Nepal, definitely if you can estimate the same kind, we will be handling the huge sum, which will be a great burden for the for our countries. So, but one very positive thing, despite all this story, is not an inevitable consequence of aging. That means we have a say whether if you do it appropriately, we can help them prevent from falls, or also help them reduce the number of falls, and therefore these consequences can be avoided. Now, what is this prevalence? So having understood falls, having understood there are three important components, systems, it's important for balance, and we have to know then what is the consequences, really big burden. Now, what is this prevalence of falls among elderly in any of these things? Worldwide, it says anywhere between 28 to 35 percentage, and among them, the mortality is almost 11 percentage. In India, it is anywhere almost the same as world scenario, and mortality is 14.9 percentage. Nepal statistics shows 30 percentage at the end, and there are not very few studies are available, but in terms of mortality, that means number of people who had falls and related injuries, and their mortality is almost 17.14. Now this is one of the key points that each one of you should note down, that 30% as well as the mortality. So when you say COVID, the COVID say the number of death is fatal, it's not fatal in most of them, it is less than 3 percentage. But when you look at falls, it is more than 17 percentage among them. So it is very much important aspect that we have to see whether we can pursue it and see whether we could contribute in reducing the falls, having known that vision and related issue is a bigger challenge. Now, some more statistics. One third of those 65 years and half more than 85 years fall each year. Go and ask anyone around your place. Probably you will get the data, because I don't see Nepal data is different from anywhere in the world too. Try to look at and try to ask. They might be neglecting it. They might not have had a very fatal accident. It might be minor too. Maybe this time it might be minor. Maybe later it might be fatal in the next thing. So ensure that if you can get this data, and if you can probe into which are the possible causes, or help to get by referral appropriately what are the possible causes, and if it is related to vision, you try to contribute to bring down. And falls lead to a moderate to severe injuries. The fear of fall and loss of independence and death in one third are very, very critical consequences we have to keep back of our mind. WHO says one-fifth of fall related death in India. We don't have such data available in Nepal. I couldn't find out. Probably one of you can find out and see. But irrespective of it, it says falls is an important community issue, especially among elderly. And we should, as whether you are in India or any part of the world or in Nepal, this is very, very critical. Having known that population, especially an elderly population, is going to add bricks in that area, we have to be very, very careful that we have to prepare ourselves to deal with this uh, geriatric giant. Now, facts about some of falls is the common fall related injuries happen because of trips, slips, and stumbles, where they might have not fallen or they would have fallen. And 27% happens due to loss of balance, which we know what are the reason: dizziness, fainting, or seizure. And these are the commonest thing which patients self-reported causes or being given in most of the literatures. And environmental hazard is the second most cause, especially related to walking up or down the steps, walking up or down the stairs, or the curbs. All these things are contributing environmental hazards. Now, as an optometrist, you can play a simple role by, if the session says that there is a fall, what else that you can ask? You can tell them, yes, you have falls, and you try to see whether in and around there is any cluttered objects around a walking area, whether you can ensure that those things are not in your place. So these kind of small inputs, and ensure that there is no water, ensure that when you go to bathroom, we go for your restroom, we should be very careful. You have to take slow strides, so it is easier for you to have the balance. So injuries more associated with descending the stairs. Studies have shown that 3 times more than ascending the star. That means when a person comes down from upstairs down, you can know that they are prone for fall compared to someone walks up. But walking up also have got a challenge. As a person with visual impairment, you have to ensure that the steps which have been kept, it should be very, very careful. They will always have the raised step. They will try to keep the highest strides, and they will ensure that they don't have such difficulty when they walk through. So, put a nutshell, risk factors associated with falls were behavioral risk factors, which include multiple medication use, excess alcohol intake, a lack of exercise, inappropriate footwear. Biological risk factors include age, gender, and race. Female are more prone because of natural osteoporosis they do get. Chronic illnesses like Parkinson, arthritis, osteoporosis, physical, cognitive, affective capacities, decreased vision, all these things comes under behavioral risk factors, biological risk factors. And socioeconomic risk factors is also equally important, especially when we get into community kind of work, where you are going on offering the service they are not going to seek. Then it becomes pertinent and important to probe into whether they have had such falls. Low income education levels, inadequate housing, lack of social interactions, limited access to health and social services, a lack of community resources, and lastly, the environmental risk factors, which I feel as an optometrist, you can play a huge role. I've just mentioned some of it. It is not a complete story. Poor building design, slippery floors and stairs, looser rugs, insufficient lighting, cracked uneven sidewalks. Now, it's not difficult for us to ask such question on environmental risk factors, try to ask on these other risk factors, and also try to connect if anything to do with vision. If not, at least try to connect. Suppose someone has got a locomotor difficulty. In addition to that, he is going to have vision related problem. It's his problem is twofold. Now at least you can try to bring down by handling the vision related issues, and he is only have to handle locomotor thing. Now at least you can refer them for the locomotor related issues, where you can refer them to physiotherapists, tell them to improve on their no weakness part of things. To strengthen exercise can be given in addition to giving the visual intervention. If you're going to give strengthen exercise, probably you are helping them to reduce a number of falls. Now, the Trinity et al. Have shown very important information. Though it is 1988 document, but it is very important document. It doesn't change much. 8% fall among no risk patient, as again 78 percentage high among 4 or more risk factors. So look at all these risk factors and try to see if a person has got more number of risk factors, is prone for falls as compared to any other group. So it is important. Once again, it says that risk factors are very critical. You have to probe, and it says that more risk factor is prone for more falls. Now, put it in a very simple no way. These are the few things that we have to keep in mind. Some of the risk factors for falls: muscle weakness, history falls, especially if they have more than four and more medication, especially those medication related psychotropic, or it related to sedatives, or some of the even simple antihistamine medicine. All these things probably are the factor we should factor into. And assistive devices, it has got both beneficiary effect as well as harmful effect, depending upon how you are going to see. Sometime when you use assistive devices, you might become more careless, and probably you might miss out some obstacles in between. You might fall. So assistive devices in literatures have clearly shown it has got both benefits as well as harmful effect. So it might be a risk factor too. Arthritis and visual impairment, as you all know, depression, more than 80 years. In our case, we will say even more than 60 years. Gait impairment, especially walking up, down, these things are called gait impairment, and balance difficulty and cognitive impairment. All these things are key risk factors we can how to remunerate and keep this list in our clinics. But what is so important? Visual defect is second most risk factor. Please believe it. Next to the locomotor issues, it has been clearly said visual defect is the second most risk factor related to falls, and we should not forget that. And if it is going to be the second one, we can definitely contribute as an optometrist. Now, this is some of the simple qualitative studies. I will just share. This only has got few important aspects that I want to share with you. Qualitative studies are very critical study according to me, more than quantitative, especially especially the kind of as the issue that we are dealing with, falls and consequences. Awareness of falls and falls related, they always have the awareness saying that it is age related and it happens due to loss of balance. This awareness is there in majority of these people, and a knowledge as to what are the causative factor. Most of these people associate this to their systemic diseases and multiple medication, and some of them also associated with the physical weakness, poor vision, and diet. So kindly underline, poor vision is also being perceived by people who had falls as one of the reasons for their falls itself. So please understand, it is not only the experts, but it's also the person who the stakeholders here, in this case patient himself, feel the possible causes of the poor vision. And what are the possible barriers and what are the possible enablers? Barriers to seek the care, barriers to seek how to reduce the falls. There are three important reasons have been given, at least in this paper. One is fear of fall, second is loss of independence, and third is the depression. These three important factors that we have to account for. It is came from the stakeholders' voice, and they also thought about the reason why they can sought all these enablers is family support, home hazard, intervention, yoga, and use of assistive devices. That means people are aware that there are interventions available. There are people who can offer that service, but they also had the barriers of the fear of fall again, so that they don't want to go anywhere else, the loss of independence and depression. And they had this thing more than the financial aspects. And this study at least showed that enablers are there and people are aware, but because of the fear or depression, they're not going beyond it. Now, there is no literature per se. That literature is more specific for elderly population, but there is no literature per se on perception of falls among people with visual impairment. Now, what we did is, this has not been published yet. We are yet to submit this paper, which we will be doing shortly. I thought it is important to share with you, team, is when we did a work with people who had visual impairment at our hospital setup in South India, and we went and probed into almost 1,080 people, whether they had a fall among almost 10,000 odd people. 1,080 people, they said whether they had a fall or not. And this was done through a small interview. Cutting short the story, a majority felt that there are four areas they covered. Majority of the felt what are the possible causes for the falls. They classified it into visual related causes and non-visual related causes. Visual related causes, they said blurred vision, whether it is distance or near, field loss, decreased depth perception. Maybe they didn't use the word depth perception, they used the word equivalent to it, and night vision difficulty, because they express that when the lights are dim, they can't move around and therefore they have the fall, and glare and poor contrast. That means they enumerated almost everything which is there in the literature without even probing, without even triggering with any of these information. And non-visual classes, they also told about the cluttering and aging and systemic disease as the foremost cause for the falls, and according to them. So in terms of what is the impact of falls on activities of daily activity, they felt the lost job, restricted to home, and recurrent falls, bedridden after fall injury, or the possible impact. In fact, some of them felt they are being hospitalized. Once they come back, they are not being given rights to move around. Some of them were walking in the early morning very often, but they are not allowed to move on their own unless and until some dependent people go along with them, attenders go with them. So in terms of family, financial issues, need for caregiver, and dependence on for these people are very, very critical. So they felt not only these causes, they also said what are the impact they did today they have. In addition to that, in fact, in addition to looking at elderly people, our study looked into people with visual impairment right from 18 years onwards. There is a small difference between the two. I will be talking about it after some time. And in terms of the barriers were, they said, no, they know, they are well aware about the eye condition, their non-curable eye problem. They feel that it is a non-curable one. The doctors have already told them. So naturally, going for further eye evaluation is not going to be helpful, but they are not aware of a lot of these rehabilitation initiatives are there. So probably they should come out of that barriers, probably that aspect of it, they are sharing during the enabling factors. The fear of fall, once you had at least one fall, is a bigger challenge. They feel is a big barrier for themselves to go out, which is there in the literature also. Denial of family support, because they have to depend on people and they want to go and get the service. If the people in the family are not coming forward to give their time and support, and it is going to be a bigger challenge. Negligence by society, not giving importance, especially our infrastructures, is not conducive for them. And social stigma of blindness. For example, in fact, one of them was sharing as a middle-aged person, I have to come out of the job because I don't have a good restroom where I could access easily. I shared this information to my higher authority. Being a government setup, they didn't even worried about it and they neglected. So naturally, I couldn't do anything about it. So I have to get rid of my no job from the government sector. Social stigma of blindness is also still a bigger issue, and general weakness is also a cause of concern for these people, which I felt is really true because all these people gave their stories with quotes from their own lives. And enablers or some of this interesting one, they said improving the vision by glasses, surgery, and referral to appropriate people is one of the facilitators. They said if they get the problem of denial or family support overcome, then probably they want to seek this care, willing for regular eye examination, so that they want to ensure vision should not be the major cause. And some of them are even ready, not the young age people up to 40 years, people are not ready for orientation mobility training, but people with middle age, 45 and above up to 60 years, and some of the elderly people are open for the idea of orientation mobility training. And slow walking, especially elderly people use that as a no adaptation technique of dealing with the unfamiliar places, slow walking in a vulnerable places, and assistance for support, especially person in care. Elderly people seek that care easily than people younger age group with visual impairment. And self-confidence are the key aspects which according to them they found it to be very important. So these are some of the aspects which are the quotes that they have been given. Perceived cause of falls, impact of falls. I'm not going to read the finer things, but all it just says is what is given in the previous slides. Now, visual impairment and falls also been studied in few of the places, not extensively as we want. All of them, the paper which has come, it says it's a multifactorial, which we agreed upon. And the impairment in balance, gait, muscle strength, cognition, chronic disease, use of psychotropic medication, all these things were associated factors along with vision. When they looked into central and peripheral visual defect and association with the falls, they felt there is at least two papers are there which showed there is an association with falls. And they said there is impact of becoming very high with other sensory and balance issue. That means a person has got vision related problem. In addition to that, he has got other balance related issues. Then the impact is very high, especially the consequence which we are talking related to falls. So in a nutshell, visual impairment and falls should be looked at on these reasons. These are the reasons where we can try to see whether we can try to bring down it. One, poor visual acuity, reduced contrast. It cause can be anything. Poor visual acuity, reduced contrast sensitivity function, the cause can be anything. Reduced visual field, again, cause can be anything. Impaired stereopsis, it can be anything. Cataract as the foremost cause. And they found that if a person had got visual impairment, what is the natural aspect happens is they will have the fear of moving around. If they don't move around, they are not going to exercise their body. Naturally, the consequence of not doing that, they become weak, especially on the lower limb side, and those people are prone for falls three times more. They will have three times more falls compared to other people with visual impairment and ensure them the activeness. Now, this is very simple implementation. When you say a person with visual impairment, you always encourage them, in addition to that vision related intervention, tell them you also should do at least some amount of walking. There are some elderly exercise where you can sit on the chair and do it. Maybe you can gain that information from some of the physiotherapists and give them some of the tips, like what we give as 20-20-20 rule for any digital eye strain. A similar thing can be extrapolated here, and tell them that early morning you can just do for 10 minutes and 15 minutes of this exercise, and just being a visual impairment, they're going to reduce the falls. I feel this contribution is going to be a phenomenal one and important. Now, this is another part of our study, which again, it is in the writing up stage, is the prevalence of fall among the visually impaired, especially in a tertiary eye hospital. We found that the overall prevalence is almost 14.8%. Because it's a hospital-based population, it is not a community-based. So naturally, it is relatively less compared to what we saw as the prevalence in, it's almost 30% or so. But the interesting thing is, you look at these three groups, there is no big difference in terms of falls, and naturally, elderly group are more prone. Look at the second aspect of things. They are not having fall, but they're going and hitting against or bumping against some things. Now, that if you really look at the data, the young age group, probably they are very active. They are prone for this, for bumping very, very often. So it is almost 25%. If you look at elderly population, maybe they don't move very often. They take slow strides. Probably that's the reason they don't have such faults, especially because of the bumping. So, or they might have faults per se, not having this bumping alone. So these two informations are new. To best of my knowledge, is not reported anywhere else, but it's yet to be published. Now, we come back to the other important aspect related to falls. So falls has got a lot of consequences. I said one of the consequences, the injury, especially fractures, and traumatic brain injury is another one. Now, one other aspect that we have to keep in mind, when people looked into the literatures on visual impairment and hip fractures, people with hip fractures, most of them will get admitted, and their mortality is very high. It is, and most of the time, at least few studies have shown that it is linked to visual impairment. And this study, which I am quoting, it shows that 33% were visually impaired with hip fractures in both eyes, and 58% had a distance visual acuity of 618 at least or worse in one eye with this hip fractures. That means when you're going to discuss next time, if someone says that he had hip fracture, probably associated with, is only association, there's not a causal relationship, but at least you try to ask whether they had, and the vision is good enough, then you can correlate the hip fracture with visual impairment. Vice versa, if a person has poor visual impairment, tell them to be very, very careful. You're prone for hip fracture. The reason why hip fracture is very, very critical, because the mortality rate of because of hip fracture is very high, especially among elderly, any part of the world. So it is important that we have to connect these things. Now, for the goals of falls prevention, it is only twofold most of the time: decrease morbidity and mortality, maintain patient independence, and good quality of life. If we can give this two, we are trying to do wonder. So falls prevention, if you really look, it's a multifactorial. It is not only vision intervention as shown to be very beneficial, it should be combined intervention. The first and foremost is strengthening balance by exercise. Of course, you have to look at possible risk factors, possible causes, as I told, vestibular, somatosensory, or vision, and try to play on this false intervention. First and foremost, most of the time, since we deal with the elderly population, strengthening balance by exercise. Probably when you deal with a younger patient, less than 60 years, the story might be different. The visual intervention is the second aspect that we have to keep in mind. And treating diseases causing vestibular function, you have to refer them to feel the balance issue is to do with their ears. And environmental modification, like what you say in the infrastructure, you can always play a role there. If you have an opportunity going to their home and try to give them some input on the environmental modification to the extent that you could, and visual intervention, these two play two things that I feel strongly that as an optometrist, you can play a role in the false intervention, and refer them for strengthening the balance of exercise, and follow up if you can gain, ensure that by asking whether you're doing this exercise or not. And if you can put this visual intervention and falls in a simple way, having known that what are the visual functions are associated visual of this falls, then you can look at curable vision problems and non-curable vision problems. Curable vision problems, try to handle it by giving appropriate glasses, advice for cataract surgery if he has got cataract, and management ocular disease. It's going to be non-curable thing. We try to keep in mind all those things which I told before. Low vision devices is one of the factor, and orientation mobility is another factor. So if you can keep these things, it is within your own purview. At least the first part, majority of these things are going to be part of you as a visual intervention. What can be done as an optometrist? Today, we might be doing all these things, but you are not linking this with falls. If you link with the falls, you can show them that it's really decreasing. The fear of fall can come down, the depression can go, all these things will be helpful. So there is a role that as an optometrist you can play in preventing falls or reducing the falls. And all we have to do, I'm going to say this is a simple step that anyone can follow, or you can modify it to in a better way. A simple way is an eye examination for all elderly is very, very critical, which most of us are doing. Try to add history about falls. I'll tell what are the possible questions we have to ask. Try to have clinical refraction, proper glasses being provided, which already you are doing. Don't depend so much on your autorefractor, especially when you're going to deal with elderly population. Stereopsis, contrast sensitivity function, and visual field. Whichever type of stereopsis you use is fine. Contrast sensitivity also, whichever contrast sensitivity tool you use is also fine. A visual field as much as possible if you can, because the challenge is more when it's come less than 30 degree. So you try to use a simple germ screen, and if you can use any of the kinetic perimetry is well and good, and ensure that you have the ability to diagnose some of these key condition which is associated with visual impairment or contrast sensitivity function, or if it is going to happen in one eye, the stereopsis. All these things are contributing factor you have to keep in mind. Now, to put in a nutshell, when you have a false patient, what are the possible questions that you can fall? The proper false history, it should be very, very critical. It is not complete, but I'll try to see whether these are the key things that you have to ask. Depending upon the patients, you can vary it. The frequency and previous falls is very important. Kindly note down number of times of falls. The reason is, if the person had only one fall, it should be seen differently. You are looking at more of preventing further falls. If the person had got many falls, he already got into a risk factor called fear of falls. So naturally, his tendency to walk around exercising will usually come down, which itself will act as a big risk factor for falls itself. So this becomes frequency of previous falls is very important, and location of falls, whether it is going to be indoor and outdoor, will give. That means even if he's a familiar place he has a fall, or unfamiliar places he has got a fall, a date and time of falls, how many months back, morning, afternoon, evening, or night, all these things will be a contributing factor. Injury after falls, whether he had a consequence of bigger in nature, or he had a fracture, he had a head injury, concussion injury, all these things will decide and help us what kind of falls he had. And perceived reason of falls, whether it is vision related or non-vision related, and recurrent falls and history of bumping against objects, are all these things pertinent question we have to ask as an optometrist to more understand about the falls. Other details, naturally, general health and medications, as I told before, past ocular surgeries, living situations, and fear of fall. All these things are very, very important. Comprehensive eye examinations and assessment of the function are very, very important for us to contribute in this area. So appropriate referral by optometrist. So once you do complete examination, appropriate referral is very, very important. There are two people that you should have some contacts. One is the physiotherapist for falls related to general weakness, and ENT specialist for falls related to vestibular dysfunctions are very, very important. And rehabilitation specialist, counseling and orientation mobility. And many places I've seen optometrists themselves learn this orientation mobility training and offer the services for low vision. Same thing can be extrapolated to these patients and try to offer it. So you have a proper role, the role of assessing it, a role of doing some intervention, and role of referral. There are three important components we can see as an optometrist you can play. Now, these are the two. This is one study which I want to share. It's not per se, it's a study, it's a meta-analysis of 7 RCTs, which done over a period. It was published in 2015. Putting the thing to short, when they looked into people with visual intervention, visual problem, whether visual intervention alone is adequate or we require to do something else. And they looked into all this study and they came to a conclusion that it is not adequate to do visual intervention alone, unless and until you look at what are the risk factors for which these patients fall. That means in addition to visual problem, they had any other risk factors, and try to plan your strategy of intervention. Then those are the strategies are very successful, at least in according to this meta-analysis done in this thing. It is an easy meta-analysis work. And this is the recent one, 2019, which came in British Journal of Visual Impairment, which shows in a nutshell, it says it is again 15 RCT, not RCT, 15 studies have been put together. The systematic analysis was done, and they've concluded that especially people with visual impairment, environmental adjustment emerges having the best evidence for fall prevention for people with a visual impairment. We have to see these systemic analysis with not with strong evidence, because not all the studies were taken as RCTs. But still, this information is very useful. As I told before, it is not only visual intervention, but also the environmental adjustments play a critical role in bringing down the number of falls among the elderly. Now, there are a few tips which will be useful, again, based on some experiences and the literatures. Studies linked the incidence of falls with bifocal and varifocal spectacle wear, even in long-term wearers. There are some controversies. People claim that progressive lens doesn't have that effect, but we should not take risk, especially in elderly people. And effective falls prevention strategies will be, if you feel there is a history of falls and the person is only a long time wearer even, then you advise him to go for single vision lenses, at least for outdoor activity, at least for unfamiliar areas. Avoid large changes of power. If there is a power change, only controversy is if the person had a cataract surgery, and if there is some amount of power change, since we don't come across such things very often, we not to worry much, but avoid large changes. They say the cutoff of 0.75. Depending upon your experience, you can always decide. But our experience and the literature clearly says, you don't go beyond 0.75. It is difficult for them to accept that change, and they are prone for fall again. So optometric intervention for falls try to have in mind the magnification factor, the decentration of the lenses, what are the lens type we use, lens design you use, position of the bifocal and progressive lenses, how it is being fitted, increased activities with new glasses, and large change in power. All these things are contributing factor. You should not miss out these things when you're going to prescribe glasses. And always keep in mind, vestibulo-ocular reflex are gained by the extraocular motility and head movement, and the swim effect can be avoided. Like what you people advise, the head movement, and therefore you avoid any of these falls is very, very critical. And summary, risk of falls, keep in mind what are the possible risk of falls such as enumerated, and glass history is very, very important, so that what type of glasses they wear, and that probably is a possible reason for the fall. And walking steps, stars, and challenges are very, very critical. Try to ask specific questions on it to prevent falls. Try to ensure, I'm reiterating, glass prescription do not change. As much as possible, have a conservative approach. Maximum change is 0.75. Minimum cylindrical axis of 5 to 10 degrees oblique axis. If no difficulty with vision, broken, change with same power. Don't try to bring in new types and designs, especially for people who are prone for falls. Warn patients about magnification effect, myopic, hyperopic, astigmatic effects. Optic centers are very, very critical, and high risk of falls, no pause on bifocals or even monovision in these groups. This is by experience. You can go by your experience, especially whenever you feel there is a long-term bifocal wearer or progressive lens wearer, and it is a minimum ometropia. Sometime we have given a prescription, we told them to continue. But if there is a significant emetropia, ensure that single vision being given for outdoor activity. Sunglasses we can give depending upon how is the vision. And few outdoor activities, if they want to wear it, teach them the technique of tuck their chin in so that they can see below. You should not have a big pantoscopic tilt there, so that you have some space between the chin and cheek and your glasses, so that that is the place through which they have to see. Especially when they want to see through the glass, they might miss the steps or things below. So it is important to say that tuck their chin in as a simple technique. We can use it. And first time wearer, single vision in addition to bifocal, and all again been reiterated. And the +1 ad is sometimes been advised for people, especially walking down the step, to see things steps clearly. But that is needs more evidences. We have tried with few people. A few people are successful. People didn't like that kind of approach, but they required more evidence on that ground. To put the whole thing into a nutshell, visual impairment is strongly associated with falls and hip fractures, and the rate of falls in older people with visual impairment is 1.7 times higher than other old people of the same age. With hip fractures, it is 1.3 to 1.9 times higher. If you remove the cataract, you can bring down the falls to almost 34%. The home safety assessment modification given to them, coping strategy advised to them, bring down the falls by almost 41%. Believe it, visual intervention alone will not help. Try to look at other risk factors and strategize accordingly the intervention. It will be more effective and more. In addition to that, the recent literature talks about try to keep in mind the environmental modification as a foremost thing in addition to visual intervention. Believe it, poor contrast sensitivity and decreased depth perception appear to have strong association with false risk. If you come across with a false and if you feel there is an associated reason, try to see anything can be done to enhance it. And wearing incorrect prescription glasses is a simple thing we can always avoid it, which naturally you will be doing. And not wearing the glasses, try to see how you can improve or enhance their compliance of wearing. So try to again reiterate, better avoid bifocal and progressive lenses, especially if it is with a history, with a person with a history of faults. I think that brings down my talk. And if you have any question, I'm open and hope it's useful.
Thank you so much, Dr. Krishna, for gracing us with your invaluable insights.
Yeah. Yeah.
Yeah, now we can proceed for the discussion session.
Sure.
Let me check out the questions that our audience might have raised.
Yeah.
If you are having any queries, then you can come up with your questions on our chat box. Dr. Krishna will be happy to answer all your queries.
Okay, no questions?
We don't have any now.
You don't have questions? Hello?
We'll just wait for a few minutes if anyone asks.
Hope people understood what I spoke. Am I clear?
Yeah, sir, you were clear.
Yeah, okay.
Thus far, there is no any questions. Considering the time limits, herewith I announce the closure of discussion session. I would again like to express my immense gratitude towards our presenter for today and as well to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for iTalks program. Before wrap up, I request our today's presenter, Dr. Krishna, to share his few words to our program. Hello, Dr. Krishna.
Yeah.
Can you share your few words wrap up?
Oh, okay. No, I want to reiterate that as an optometrist, at least start asking question to all your patients with visual impairment, irrespective of the age, about the history of falls. And if they had any falls, try to find out whether it is because of poor vision, whether it is because of ear problem, whether it is because of their locomotor problem. I feel if it is going to be locomotor or vestibular, you suspect, even if you suspect, kindly refer them to appropriate expert. And if you feel that it is because of poor visual impairment, try to see that interventions have been appropriately given. The second important message I want to say that if you have the elderly patient with a history of falls, if he is wearing a bifocal or progressive lens, educate him to avoid using it in unfamiliar places and outdoor activities. and outdoor activities to suggest them to use the single vision glasses. I think that is the take home message which I want to reiterate. And especially the third one, especially countries like us, the cataract, the person will undergo one eye, the other eye they will avoid or they will delay it. Even that is also found to have a big effect on depth perception and therefore falls. So encourage people. Studies have shown that if both eyes have got operated, the falls have reduced almost to 34% among the elderly. So since it is very costlier aspect, the big burden to the country and to the family per se, I feel as an optometrist, people should venture into understanding this, and people should try to have this as one of their expertise area, offering a service to reduce falls. Believe it, countries like us, we are going to have increased number of elderly population in the years to come. Thank you. Thank you.
Thank you, Doctor. It was great to have you.
Thank you.
Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you.
Thank you all. Thank you, Kapil and Solu.